question, I have to stop antibiotics in sepsis. My conflict of interest, some of them in relation with this talk, or as an industry, I don't want to stop. Our daily challenge is to provide the best care to our patients to improve their survival and their outcome. But on the other side, we have other responsibilities. And in terms of infection, is to decrease or reduce the emergence of resistance with real risk at the collective level. And you all know that, but also at the individual level, since around 50% of your patients with septic shock, when they survive, will be rehospitalized in the year. And if they have some resistant bug, the risk for their future hospitalization and their outcome will be poor. And each time you gave a treatment, and especially in antibiotics, there is some adverse events, and these effects can be related to the treatment, but can be also related to the spectrum, and I will present you some very interesting data on that. So I have to stop. I will share the talk in 3 parts. Do not start, do not misuse, and do not prolong. I will start with do not start because it's not really simple to stop a treatment. And in my view, the most simple, very, very often is do not start the treatment. And I think that we start antibiotics too easily today. So first, think at the cause of the shock. And your shock can be a septic shock, and you will find that that's the shock, the responsibility for the shock. But in fact, it can be a cardiogenic shock. That can be a bleeding. That can be a pulmonary embolism. And
sorry, Marc,
yes?
I interrupt you, but I think there's issues to see your slides that coming from the audience. So I don't know if the team can fix that.
Should I restart that? I'm going to share again my office. Is that fine with you?
Yes, it's okay for me.
It's okay. Hope it's okay for the audience.
Hope so.
So the cause of thank you. The cause of shock is not always a septic shock, and I think that the weight of septic shock is too large today. And if you have a cardiogenic shock, you don't need antibiotics. The cause of infection should be found, because if there is no infection, if there is no source of infection, there is no infection, and fever is not enough. I like this study from a Spanish group showing that following pulmonary, following digestive surgery in the day after, when you have a postoperative pulmonary complications, pneumonia is responsible for 1.8% of those complications. So be very careful each time you have a pulmonary complication. That's not a pneumonia, for example. And I like this now pretty old study from a group from North Carolina in the US. They compare, that's not a randomized clinical trial, that's a before-after observational study, but they compare an aggressive protocol, less or more responding to the surviving sepsis campaign recommendations. And as you see, after sampling, the duration between fever and the the use of antibiotic was 11 hours. That's long, but that's not too long in practice, in fact. And they had a conservative group with a conservative protocol, and that was longer, 35 hours, because they just wait for the result of the lab. Not in shock patients, but in patients with sepsis. And in this study, the better outcome were reported in the conservative group. Of course, we should give antibiotic in 1 hour, before 1 hour in patients with septic shock, but this should not be applied to all patients. So start very early, as soon as possible, but only in patients with septic shock and not in all patients with sepsis. My second step is do not misuse. When you use antibiotic, all is in the timing. And we have the first period of empirical treatment and the second period of directed treatment. The empirical treatment is start after the clinical suspicion, as soon as possible if there is a shock, and the directed treatment starts when you receive the lab result. And that's very important now to have the result of rapid diagnostic test, and you can have some in 1 hour, other in 3 hours, to reduce this time. We overuse probably combination. Combination is not important for directed antibiotic, except if you have pan-drug-resistant bacteria or an extensively drug-resistant bacteria, which are resistant to all antibiotics. And in this case, you can combine several antibiotics to try to find a solution. But in most pathogens, including Pseudomonas, you don't need to have combination. You probably need combination for allergic, for broadening the spectrum in empirical treatment in patients with septic shock. But be careful not to use too broad spectrum antibiotic. And I like this recent publication from the NIH group in Baltimore, I think, showing that when you use unnecessary broad antibiotics, you can have an over mortality. So if you miss your bacteria with an adequate treatment, you have an over mortality. But if you use a too broad spectrum antibiotics, you have also an increased mortality. That's a kind of U curve. That's an observation study. That's not a randomized clinical trial, but that's the first red flag on this point, and I think it's important. And anyway, if you use beta-lactam with aminoglycoside, for example, in septic patient, stop the companion agent. It has the aminoglycoside as early as possible, because most of the time, and in this meta-analysis from the group of Mika Paul, you can see that there is no role for there is no benefit to use an aminoglycoside. So the third step is do not prolong. First, if you're wrong, and we can all be wrong, I can be wrong, everybody can be wrong with starting antibiotics, stop it. And stop it the day after or 2 days after. But we can all start the treatment. And if we need to stop, we stop. There is no individual susceptibility. There is nothing. We have to stop if it's not necessary. And sometimes 1 day after, we can say, oh, that's just an atelectasis, and I did a wrong diagnosis. Second, short duration should be used as a simple rule. For example, if you have a patient with ventilator-associated pneumonia, the duration is 7 days. And I like this our study now from the group of Shastre, showing that 8 days is as efficient as 15 days, with less multi-drug resistant bacteria and superinfection in the group treated 8 days. You can tell me, oh no, I use the clinical and biological variables to stop my treatment because I'm very clever physician and smart, and I look at my patient. I'm a very good clinician, but you are wrong probably, because when you look at this study, there is no difference in terms of clinical and biological variables between the two groups. And as you can see, for example, in terms of leukocyte, there is still patient with high leukocyte after 10 days, for example, or at day 7, there is still patient with fever, and they stop the treatment and there is no difference. The first time is an infection, after is an inflammation, and inflammation doesn't need antibiotics. So in case of that, stops your treatment at day 7. In case of intra-abdominal infection, there is a stop-it study showing that 4 days is enough. You don't need to prolong your antibiotics later. And there is, I think, around 17 ancillary studies confirming this in all the subgroup. But that's not only ICU patients. In ICU patients, there is this excellent study from a French group led by Montravers and Dupont, showing that 8 days is enough as compared with 15 days, with a decrease of 15% of the use of antibiotics between day 8 and day 28 in the group 8 days. This work in all the subgroup. We should note that there is more fistula in the 8 days group than in the 15 days group. So all is one, a short duration, even for intra-abdominal infection, when the source is controlled. When the source is controlled, that's very important, is enough. Very important, if you take samples, consider them. And if they are negative, you should stop your treatment. If there is no bacteria, there is no need for antibiotics. And that's very important to have this in mind, to keep this in mind. If there is no bacteria, if there is no source of infection, there is no need for treatment. And in two observational studies, when they stop treatment in patients with negative culture, and they have no difference in terms of outcome. Of course, you have to look elsewhere, because perhaps it's another infection, another source of infection, and you miss one, or another cause of organ failure, and you need to look for another diagnostic. Anyway, the discussion now is probably to have an ultra-short treatment versus a de-escalation in most patients. And de-escalation occurs at the time of lab results are produced. And as you know, the de-escalation is associated with the same outcomes than continuation of treatment. De-escalation is not so often performed in the world. We have a recent study showing that de-escalation is performed only in 16% of patients as a Dana study. But de-escalation in Oxford study is always associated, or most of the time associated, with an increased number of antibiotic days, probably because physicians are less attentive when it is basic antibiotics. And I like this study from the group of Compass, showing that in most patients, 3 days of antibiotics should be enough to treat a suspected ventilator pneumonia, and that's perhaps the future. And perhaps when we de-escalate, we can stop the treatment because there is no more bacteria or no more big inoculum. And I like to remember this old study from 2000 from the group of Singh, showing that 3 days of ciprofloxacin was effective to stop treatment in 70% of patients, with a reduced duration of ICU stay in the patient in which the treatment was stopped at day 3. So perhaps de-escalation is just a reflection of our excess use of antibiotics. Perhaps we should combine de-escalation or stopping antibiotic with the use of rapid diagnostic tests, but that's for future. And if there is no consensus in your team, why not to use procalcitonin? You should use procalcitonin from a stringent fashion using high cutoff at 0.5 or decreased by 80% in patients with the source of infection well documented, and in severe patients. And in this case, you can have success using procalcitonin and reduce the use of antibiotics. That is well demonstrated in several meta-analyses now. In complicated infection, deep infection is much more complicated. There is no fixed duration. That should be a personalized approach. Using tissue samples and culture, repeated culture, using CT scan and ultrasound. And keep in mind that the day when there is no bacteria, there is no need for antibiotics. And that's the same code that used Mauricio previously. Is a clinical problem still there? And that's the question. If the clinical problem is not still there, you should stop your treatment. And probably that's the summary of my talk. In uncomplicated infection, in VAP, 7 days if you have conservative, 3 days perhaps if you have aggressive, 8 days in intra-abdominal infection, 4 days if you are aggressive. There is some uncertainty with Pseudomonas aeruginosa and Staph aureus. We need more publication. You should be based on PCT. And in complicated infection, you should have a personalized approach based on image and sampling. So more is not always better. You are never alone to decide. And in case of infection, keep calm and change a winning team because we need to reassess. Thank you for your attention.
Thank you, Marc, for this really nice presentation, and you provided us very clear messages for our practice. And I think the COVID-19 situation is at high risk of antimicrobial overuse. So thank you very much. Maybe just time for a very quick question. Maybe Philippe, or if it's okay, we can maybe conclude this session. It's just we are just on time. So Philippe, I don't know if you want to say something.
Just maybe a quick question. If your patient is under, let's say, 90% of oxygen intubated, and you see that it's not moving on, and you have like a chest X-ray that is worsening, with a lot of sputum and things like that, but that is not in shock. You don't have like much room for an optimization. Would you start antibiotics or not, or use like maybe the film array? The film array is really a good option.
Yes, our guidelines in this case invite you to start antibiotics, to start empirical antibiotics, but be sure that there is no other complication, because the problem is that if you have a pneumothorax, for example, or something else, you can miss the good treatment, and the use of antibiotics is not enough, and very frequently we miss the good diagnosis because
this
we
is
are antibiotics are reassuring.
Yeah, definitely.
Thank you very much.
Thank you.
So I would like to thank all the speakers for their very nice talks today. And I would like to thank the scientific committee of our society for inviting us today, and enjoy the e-Congress. Thank you very much.
Thank you. Thank you.
Bye.